This segment is on angina and myocardial infarction. As we start to talk about these, the first thing I want us to do is take a little look at the difference between angina and MI. So you can see that angina up here, all this yellow stuff is supposed to represent for us atherosclerotic plaque formation. And notice that in angina, the vessels are narrowed. They've become somewhat more rigid, but there's still some space in there. There's some opening in there. So when your heart needs to work harder and those coronary arteries need to dilate, they can't do it. And so there's a decrease in the amount of blood supply to the heart muscle temporarily with that. Now with a myocardial infarction, we've had maybe a few more trips to some of the fast food places, a few more high-fat meals, and what happens is a couple more meals and this vessel may totally block off. Or we have a very narrowed vessel over here and a clot has broken off. So there's a piece of clot and it gets to a point that's narrower than it is. And there's your embolus. Over here we call that a thrombosis, and here's embolus. So an MI is a complete obstruction of a coronary artery. So there's a complete blockage of blood to one or more areas of the heart, whereas angina is a temporary obstruction of blood flow to the myocardium. We can define angina as transient chest pain caused by insufficient blood flow to the myocardium, resulting in myocardial ischemia. Now, what brings it on if it's transient? It's not there all the time. The precipitating events, exertion, that makes the heart have to beat harder and need a greater blood supply. Excitement, again making the heart beat faster. Environment, either very hot or very cold. Eating large meals. All of these things may be precipitating events. I kind of group them under the E words, as you saw. Another thing that can bring on a anginal episode is nicotine, because that's a very potent vasoconstrictor, so that can bring on an anginal episode as well. Now, if we think about nursing care related to the patient with angina, this patient is likely to need oxygen if they have ischemia. Of course they need oxygen. Nitrates are vasodilators. Calcium antagonists and beta blockers are frequently ordered for these patients, and we'll talk about those in more detail in a moment. This patient needs teaching about a low-sodium, low-fat diet. Smoking is a vasoconstrictor and should be avoided. A regular, moderate exercise program is appropriate to prevent anginal episodes, but that should be done under the guidance of a physician. And obviously, you would teach him about his medications. Let's take a look at the nitrates. A very important category of drug in the management of patients with angina. Nitrates are powerful vasodilators. They decrease the myocardial oxygen needs by dilating vessels. They also increase the blood supply to the myocardium by dilating the coronary vessels. Now, let's think about this dilation, vasodilation. The nitroglycerin will dilate coronary vessels, and when it dilates coronary vessels, of course, that increases the blood supply to the myocardium. But it doesn't limit itself to coronary vessels. It also dilates peripheral vessels. And when it dilates peripheral arteries, that reduces the venous return and reduces the cardiac workload. So this is how it reduces the myocardial oxygen needs. Now, nitroglycerin also dilates cerebral vessels. And when it dilates cerebral vessels, this is why the patient complains of a headache sometimes when you give them nitroglycerin. They'll talk about a headache. That's the cerebral vessel vasodilation. When the peripheral vessels dilate, a side effect that we see is hypotension, orthostatic hypotension. This can be so serious that when you are teaching a patient about taking nitroglycerin, you must tell them sit down or lie down when you take the drug. Never take it in a standing position. If the patient is standing when they take the drug, that vasodilation may be so much and the orthostatic hypotension that they will faint. So that would be a very important teaching information. Now with the nitrates, remember that you give the nitrates sublingual, and that means under the tongue. So let's say the patient had sublingual nitroglycerin at 10 o'clock and their chest pain is not relieved. Could you give them more? Yes, at 10:05 you could give them a second dose. It doesn't relieve the chest pain. At 10:10 you could give them a third dose. If there's no relief this time, then it's 911 time, or time to call the emergency medical personnel. So you can give sublingual every 5 minutes times 3 doses. Nitrates should be put in a glass container, so a dark glass container. The nitroglycerin should not be touching plastic. If there could be a plastic container outside the glass one, but it should not be touching plastic. Nitroglycerin is very sensitive to light, unstable in light, so it needs to be a dark container. It's unstable in heat, so it needs to be stored relatively cool environment. Humidity also shortens the shelf life, so you don't want to put it in the refrigerator. Now, nitroglycerin can also be given as a paste, and you kind of see that picture here of it as a paste. It always amuses me to measure the drug in inches, but you remember that's exactly what you do. You measure it in inches, and then you put it on a relatively hairless area of the chest, shaving it if need be. Remember, when you are giving a second dose of the drug that you've given by paste or patch, you remove the previous dose. Typically, however, the patient will have it on for a few hours and off for a few hours, but you certainly must remove the prior doses. You don't want them to have patches or paste all over the chest region. Another drug that's very important for us in talking about management of angina are the calcium channel blockers. So the calcium channel blockers, drugs like nifedipine. Now if you look at the trade name Procardia, you'd know it was a heart drug, wouldn't you? Diltiazem, Cardizem, you'd know it was a heart drug. Verapamil, but look at the trade name, CAL, calcium AN antagonist. You'd know this was a calcium antagonist. These drugs, the calcium channel blockers, are used to treat angina and sometimes also atrial dysrhythmias. So you might see somebody in atrial fibrillation on diltiazem, for instance, commonly prescribed for that. They decrease the myocardial oxygen need. They have drop in blood pressure and orthostatic hypotension as a major side effect. Notice that the actions and side effects are fairly similar to those of nitroglycerin. As with any of your cardiac drugs, you would want to withhold the drug if the systolic blood pressure goes below 90 or the pulse is below 60. And these are adult numbers, but those would be good numbers to recall. Let's do a question. A 56-year-old man has angina pectoris. He has been having an increased number of episodes of pain recently. During admission, he tells the nurse he has had several episodes of chest pain in the last week. Which statement is of greatest concern to the nurse? 1. I had chest pain while I was walking in the snow on Thursday. 2. We went out for a big dinner, but I couldn't enjoy it because I got the pain before we got home. 3. I had chest pain yesterday while I was watching television. Or 4. I felt pain all the way down my left arm when I was playing ball with my grandson. And the correct answer is number 3. Now let's take a look at the data and the question. So he's had increased number of episodes of pain recently. He has angina. He's had several episodes of chest pain in the last week, and we're looking at greatest concern. Now what makes 3 the correct answer? This is pain at rest. So if pain at rest is either unstable angina or could even be signs of an MI. Now the other answers, if you notice, are all those E words we talked about. Number 1 is exercise and environment, the cold snow. 2 is eating, and 4 is exercise. Now some of you might have liked answer number 4 because 4 has radiating chest pain. Radiation isn't what separates angina from MI. It's whether the chest, when it occurs. Now chest pain that occurs at rest is more apt to be an MI. Anginal pain is relieved by rest and nitroglycerin. All right, I have another question for you. An adult male has angina pectoris. Which statement the client makes indicates he understands the necessary modification in lifestyle to prevent angina attacks? Number 1, I know I will need to eat less, so I will eat only 1 meal a day. 2, I will need to stay in bed all the time so I won't have the pain. 3, I'll stop what I'm doing when I have pain and take a pill. Or 4, I will need to walk more slowly and rest frequently to avoid the angina. And the correct answer here is number 4. I will need to walk more slowly and rest frequently to avoid the angina. Notice what the stem up here said. Modifications in lifestyle to prevent angina attacks. Now most of you probably eliminated 1 and 2 and we're trying to choose between 3 and 4. 3 treats, 4 prevents. So make sure that you pick up those key words in the questions. And I have one more anginal question for you. An adult male who has angina pectoris says to the nurse, "I'm afraid I'll have a heart attack if I have sex." What is the best response for the nurse to make? 1, the doctor should be able to help you. 2, have sex only when you have not been very active for several hours. 3, you should not have sex for several more weeks. Or 4, try different positions that require less energy. And the correct answer here is number 4. Try different positions that require less energy. Reduce the cardiac workload. Note that answer number 3 really says don't do it. 2 says only when you've not been active. And 1, it says don't talk to me about it, go talk to the physician about it. The nurse should be able to discuss this topic with the patients. Now, typically when patients who have angina, or even those patients who've had an MI, are concerned about sexual activity, we have noticed a number of things. Typically we tell them if they can climb 2 flights of stairs without chest pain, then they probably can safely have sex. That's one guideline that we have sometimes given to patients. Sometimes we tell patients to take nitroglycerin before, but there's a little caveat here. No nitroglycerin if the patient is taking drugs like Viagra or Cialis, or maybe I should say no Viagra or Cialis if they take nitroglycerin. That could cause too much vasodilation and an unsafe drop in blood pressure. We've also sometimes tell the patient this. Heartbeats stay at normal rate when one beds down with legal mate, but roosting in another's nest flirts with cardiac arrest. Now, just to be sure that makes sense to you, I'm going to tell you a story. that one of my students told me one time. As I was teaching a class, a student raised his hand and wanted to share a story. And as he was telling the story, while he was in nursing school, he was working as an emergency medical technician with the rescue squad in the rural area in which he lived. And one night he went out on a call and they picked up a man who had obviously had a heart attack during sex. And they got to the small rural hospital that serviced that area, and the nurse on duty in the emergency department was the patient's wife. Now, he had been roosting in another's nest. And it's interesting, but we have noted over the years that it would appear that most of the difficulty with heart attacks and sex actually happen when people are not bedding down with legal mate, shall we say, when they are on some illicit episodes. Now, that's not to say a person couldn't have a heart attack at home with their spouse, but very often it occurs under other circumstances. Now I want us to talk a little bit about the big one, as I sometimes call it, myocardial infarction. This picture shows us what happens. Right here you can see a blockage, a clot, an obstruction. And this area of the heart muscle is not getting any blood supply. So this coronary artery is blocked and you don't get a blood supply to the rest of the heart muscle. Would you say this was a major heart attack or minor? That's right, it's a pretty major heart attack. This is a pretty good-sized heart attack. So we can define an MI, or a myocardial infarction, as the death of myocardial cells from inadequate oxygenation. So when we talk about the signs and symptoms that the patient presents with, pain, usually it's substernal radiating. This chest pain is sometimes described as being vice-like. It is not relieved by rest or nitroglycerin. Frequently, patients who have this very severe pain will also have nausea and vomiting, sweating, shortness of breath. Men who are having a heart attack, you ask them to rate their pain on the 0 to 10-point scale, and they'll tell you 12 or 15. Now, that's a typical male heart attack. Women may be atypical. In other words, the woman rates her pain as 6. The woman says, I've got just a little discomfort or tightness in the chest area. She may or may not, she doesn't usually have those real dramatic kinds of symptoms that we associate with the TV heart attack or the male heart attack. So oftentimes we miss women's heart attacks. People say, here, take some Maalox and go home, rather than getting a thorough workup to pick up the changes in enzyme levels and to make that diagnosis of a heart attack. Now, obviously, if they do blood work on the patient, you would see changes in the enzymes. Those enzyme levels would be elevated. And if they do ECGs, you're likely to see the ECG changes. But it's important they must do those tests in the emergency room in order to make that diagnosis. A question for us. The client is admitted with a suspected myocardial infarction. The client's 12-lead ECG showed an elevated ST segment. What is the significance of this finding? 1, the myocardium is irritable. 2, the serum potassium level is elevated. 3, the myocardium is not receiving enough oxygen. Or 4, the electrical conduction is being slowed through the AV node. Now, you may know about the ST segment changes. If you do, you know the answer is number 3. But you know what? You don't have to know that to answer that question. If the patient was in with a suspected myocardial infarction, what's going on? The myocardium is not receiving enough oxygen. So even if you're a little fuzzy on your ECGs, you should be able to answer that question. I'd just like to point out to you when there is more than one way to get the correct answer to a question. All right, so now let's talk about MIs and what is done for patients who have MIs. Antiplatelet meds to stop the clotting process. Sometimes it's as simple as an aspirin. We often tell the public, if you have symptoms of a heart attack, take an aspirin. Some patients might be given Ticlid or Plavix, but these are drugs that will help to keep more clots from forming. Oxygen is a very high priority need for patients who have NMI. So they would need oxygen. They need a patent IV line for medications. The drug of choice for pain management is morphine, and the route of choice is IV, so that patent line and morphine IV tend to go together. ECG, we want electrodes on the patient as quickly as possible because they're at high risk for potentially fatal dysrhythmias. Many patients who have probable MIs will end up with angiography and possibly angioplasty. The angiography is obviously to see which coronary arteries are affected. Now, they may also get anticoagulant medications if they have obstructed coronary arteries. We will talk in just a moment about the clot busters medication, but as we look at the anticoagulants, almost every patient who's had an MI gets heparin. Usually they get IV heparin, then at some point, not too far down the road, they will get the sub-Q Lovenox, enoxaparin or Lovenox, and that will be followed by warfarin, which is Coumadin, and given orally. All right, now, things that will be important for them a little later after the acute phase is over. Fluid balance. This is important all the way through. Remember that the urine output is an indicator of cardiac output. So if your cardiac output decreases, so will your urine output. So fluid balance is really critical. Stool softeners are more of a longer-term issue for patients who've had MIs. Now, I want us to pull out and talk about some of the drugs here. The nitrates we mentioned already. ACE inhibitors, we'll be talking about in more detail in a minute. These are your prils, and the beta blockers, the olols, are also frequently used for patients who've had MIs, and we'll talk about those in more detail in a few moments. Now, back to the thrombolytic drugs, the clot busters, as I call them. These are drugs that actually destroy clots. Now, you can tell by the ASE ending that these are enzymes. So, alteplase, which is TPA. One that's been around for a very long time is streptokinase. And these drugs actually destroy or dissolve clots. Now, not every patient with an MI is a candidate for them. One of the foremost restrictions on it is this drug must be given within 6 hours of the infarct with an MI. And by the way, in patients who've had strokes, it must be given within 3 hours of the stroke episode to be effective. So it's important that the diagnosis be made so that the thrombolytic drug can be given. Now, there are some other requirements too. If the blood pressure is too high, if they've had bleeding episodes, if they had bleeding ulcers, obviously you would not give this patient a thrombolytic drug. The major adverse effect of the thrombolytic drug is going to be bleeding, and obviously you'd need to observe the patient for bleeding. Now, if the patient is a candidate, they will have received the TPA or streptokinase within a few hours of the infarct. That will be followed by heparin. If they were not a candidate for the thrombolytic drug, they will probably get heparin anyway. Heparin blocks the conversion of prothrombin to thrombin, and in this way it prolongs the clotting time. It takes longer for the blood to clot. Now, earlier we talked about when we talked about diagnostic tests, we talked about the PTT and the clotting time, and said that these tests were used to measure the effectiveness of heparin. We even said that PTT equals H. So those two little T's look like an H to remind you of heparin. Now we've added something new to this from any earlier discussions. The antidote for heparin is protamine sulfate, and this is something you absolutely must know, likely to be asked on the test. So patients will be started with IV heparin, and that's followed by the sub-Q Lovenox. At the same time the patient is started on Lovenox, he is likely to be also started on Coumadin or warfarin, warfarin being the generic, Coumadin being the trade name. It takes several days for Coumadin levels to rise to therapeutic levels, so they'll need to be on the Lovenox until the therapeutic levels are reached, until the INRs are in that target range of 2 to 3. Now notice that warfarin works at a different point in the clotting cycle. It blocks the synthesis or the production of prothrombin. We talked in the section on diagnostic tests about PT and INR being used as tests to monitor the effectiveness of warfarin. Notice that the antidote for Coumadin is vitamin K. And that's your memory tool. K is the antidote for Coumadin. NCLEX loves to ask questions about antidotes, particularly for heparin and Coumadin. Coumadin is also known to have many, many drug interactions. So Coumadin, for instance, I know you wouldn't give aspirin to someone who was taking Coumadin because they're both anticoagulant. You'd have to be careful about over-the-counter cough and cold medicines. There are many herbal preparations that are contraindicated in patients who are taking Coumadin because they also have an anticoagulant effect. So far we've been talking about drugs that potentiate the action of Coumadin. There are other types of drug interactions as well. For instance, phenobarbital and sleeping medications, barbiturates, will actually block the action of Coumadin. So any patient who is taking Coumadin really needs to ask their physician about any kind of drug or herbal preparation that they're taking, because there are many, many drug interactions with Coumadin. There are also food interactions with Coumadin. And one of them that comes to mind for most of you is probably going to be the green leafy vegetables. Green leafy vegetables are high in vitamin K. And vitamin K is the antidote for Coumadin. So now the key on this is that patients who are taking Coumadin should take about the same amount of vitamin K foods every day. It doesn't mean they can never eat spinach or broccoli or many of your spices, like even basil, will contain vitamin K. It doesn't mean they can never have any of those, but they should have them in consistent amounts, and that way their dosage of Coumadin can be adjusted to account for their dietary intake of vitamin K, because of course those foods contain lots of other good nutrients as well. Let's take a look at a question. When evaluating the effectiveness of heparin therapy, the nurse would monitor which of these laboratory tests? Prothrombin time, partial thromboplastin time, red cell fragility, or platelet time? And the correct answer is partial thromboplastin time, number 2. Remember that TT equals H. Now I'd like us to take a look at some drugs used to treat ventricular dysrhythmias. So if we take a look at the first one up on that list, it is lidocaine or xylocaine, and also beryllium or bretalate. These two drugs are usually given in emergency situations. So they're given intravenously and they're given for emergency situations. The rest of the drugs that are listed there in the color blue are drugs that can be given. Some of them can be given IV, but they can also all be given orally. And these are drugs that are used to slow down the ventricular rate, to make a slower ventricular rate. Amiodarone. Look at the trade name. I wish I could guarantee you trade names on NCLEX, but I can't. But you know it's a heart drug with Cardiopulmonary. Asmolol or Brevibloc. This is in the beta blocker family. Flecainide or Tambacor. Adenoside, Adenocard. Procainamide, Pronestal. Doesn't procainamide kind of sound like lidocaine? So notice the endings on those: lidocaine, procainamide. That might help you to remember that these drugs will slow down the heart rate. Sotalol is another beta blocker, even called beta pace. Now, when patients are taking any of these drugs that are going to slow down that ventricular rate, very important to monitor vital signs in ECG. Sometimes they can cause other dysrhythmias. Some of them are well known. Amiodarone can cause other dysrhythmias as well. For long-term use, these drugs should be given at regular intervals. And for emergency use, why that isn't necessarily so, but for long-term use, for instance, if a patient was to take Pronestal twice a day, and the patient says, I have it all figured out. I'm going to take my first dose at 8 o'clock in the morning when I get up, and I'm going to take my second dose at noon, and then I'm done for the day. I don't have to worry about it. Good plan? Not a good plan, because the heart will be very slow during the daytime hours and race away at night. So that would not be a good plan. If he's taking it 8 o'clock in the morning, he should take the other dose about 8 o'clock at night. Isopril and atropine should be readily available. If the systolic of the blood pressure drops below 90 or the pulse below 60, then the drug should be withheld and the physician notified. A question for us. The nurse is planning care for an adult who is recovering from a myocardial infarction. Included in the nursing care plan are measures to prevent Valsalva's maneuver. Which nursing intervention should be included? 1. Administer stool softeners as ordered. 2. Teach the client to hold his breath when changing positions in bed. 3. Serve liquids at room temperature. Or 4. Encourage the client to cough and deep breathe frequently. And the best answer to prevent Valsalva's maneuver is number 1, stool softeners as ordered. That will help keep the patient from straining at stool. Are there any answers here which might indeed cause Valsalva's maneuver? That's right. Answer number 4, that coughing may cause Valsalva's maneuver. So might answer number 2, if you hold your breath when moving. If you see patients doing that, and they do tend to do it, tell them, take a deep breath, move, breathe as you move. Another question for us. The nurse is caring for an adult who has just had a myocardial infarction. He has several PVCs per minute. Which drug would the nurse expect to administer to reduce PVCs? 1. Procainamide, which is Pronestal. 2. Phenytoin or Dilantin. 3. Xylocaine or Lidocaine. 4. Digoxin or Lanoxin. So he's just had a myocardial infarction. The best answer to that question is number 3, Lidocaine or Xylocaine. Now, interesting to note that all of these drugs are sometimes used for dysrhythmias. Procainamide can be, but it wouldn't be used for someone who just had an MI probably. That would be more apt to be a maintenance drug. Phenytoin or Dilantin we think of as a seizure drug, but it is also sometimes used as an antiarrhythmic because it slows down those nerve impulses. But probably not your emergency drug for someone who's just had an MI. And digoxin or lanoxin is used more for atrial fibrillation and atrial dysrhythmias, not really an MI type drug where we usually have ventricular issues. Another question for us. The nursing order states, observe for lidocaine toxicity. Which group of symptoms should the nurse be alert for? Circumoral flush, dilated pupils, increased pulse rate and dry mouth. Choice 2, constricted pupils, elevated blood pressure, coma, and respiratory arrest. Choice 3, bradycardia, hypotension, slurred speech, dulling of the sensorium. And choice 4, polyuria, tachycardia, headache, and increased salivation. So the signs of lidocaine toxicity, answer number 3. Bradycardia, everything slows down. Their speech, their alertness. Now, I want you to see if you can find the answer that would suggest the signs of atropine, side effects of atropine. And the best answer here is answer number 1. Those are really classic atropine side effects. Now I want us to talk about a couple other things that might be done for patients who've had MIs or who have coronary artery disease. And we're talking about an angioplasty here. So you see this balloon catheter, and it's put in, and here's your point of obstruction, your clot. It is inflated and it squishes out the clot and the blockage. The relief is immediate. Sometimes the angioplasties are accompanied by stents, and you can see a picture of a stent here that goes in, and that's to keep the vessel open. Some of the stents have coatings on them, some don't, but that's essentially what a stent looks like. Now, with an angioplasty, the relief is immediate, but it's not always permanent. Statistically, more than half of the people who have had angioplasties will end up with restenosis. Now, for some, it's very soon. For some, it takes months or years before we see a restenosis, and there are people that never restenose. But that is a risk in folks who have had angioplasties. Now, it's really important to teach patients who have had an angioplasty how to reduce the risk of another heart attack. So we need to teach them about lifestyle changes and dietary changes and getting a good exercise regimen. Another option for patients who have blocked coronary arteries is a CABG procedure, the coronary artery bypass graft. As you can see in this picture, this patient has some fairly severe blockage of coronary arteries. In fact, there's probably a trickle of blood getting through there. Otherwise, this patient would be in the throes of a major heart attack. Now, clearly something has to be done about this. So this coronary artery bypass graft, they take a piece of vessel vein, usually the saphenous vein from the leg, and create a detour or a bypass around the obstruction point. This is actually a quadruple bypass. Sometimes patients have 1, 2, 3, or 4 of these. Now, this is usually open heart surgery, and so the patient will be on cardiopulmonary bypass. They will have their chest cut open. It's a pretty long incision. They will be put on the heart-lung machine. The physician will get the vein from their leg, will do the fine sewing job, and then when they come off from the cardiopulmonary bypass or the heart-lung machine, the heart has to be jump-started many times to start again. So that means that they'll put the paddles in and give them a jolt of electricity. The sternum, which has been split for the incision, is usually closed with wire sutures, and maybe sometimes you've even seen them stick out from the skin in patients who've had this procedure done. And you would think that someone who had gone through all of this would lead a perfect lifestyle, wouldn't you? But your dietary teaching is going to be very important. Some of these patients go right back to the cigarettes and the steaks and the high cholesterol food and don't alter their lifestyle to reduce the likelihood of another cardiac episode. But we need to try and do the kinds of teaching to